Hello, everyone. We'll get started if that's okay. All right. Well, thank you all for coming today, both online and here in person. We're really excited to present the results for this study. And I just want to take a quick second to thank everyone in the audience who participated and filled the provider survey. And a really special thanks to all our patients who really took the time to sit with us and share their stories. So I have the privilege to introduce our two speakers today. So we have future Dr. Hunter Tolison. Hunter is a first-year MSDP student. He has been part of our division for some time, so a lot of you guys know him. Most recently, he was doing some really interesting research in Craig Jordan's lab before he joined our MD-PhD program. And then we have Dr. Cassandra Duarte, who is a second-year HEMONC fellow. She did her residency program here. She stayed as a chief resident, and we were really lucky to recruit her to our fellowship program. I will keep it short so I don't take too much time, but all I have to say about them is that if you have worked with Hunter and Cassandra, you know that they're nothing short of phenomenal. And it's been really such a privilege to work with them on this project. They have made it happen from beginning to end, and they put together a really nice presentation for you guys today, so I hope you enjoy it.
Thank you so much for the introduction, Maria. As always, it's an honor to be here, and this study is a little bit different than what you might see in most grand rounds. So just to preface, this is of course work in progress. You can't eliminate bias in medicine overnight. This is just us here to tell you information that we have gathered. For our talk today, our learning objectives are to describe patients' perception of the impact of race and ethnicity on healthcare, to describe providers' perception of the impact of race and ethnicity on healthcare, then to identify ways in which UCHealth can improve the patient experience within the Division of Hematology. And then the last objective is to utilize a patient-centered approach in caring for patients with sickle cell disease. And Cassandra and I both do not have any disclosures for this talk. And our agenda today is to review the existing literature of bias in medicine focusing on hematology. We'll then discuss our study design. Then we will be presenting some of the provider data we received, some of the patient data we received from our study. Then we'll discuss some common themes of our study and then develop some UCH specific solutions based on the information we've gathered. And we thought this might be a nice way to open this meeting today, is to start a poll everywhere. So if you guys don't mind either scanning the link on here or visiting the Poll Everywhere web link that's up there, we would love if you could all just enter a very short phrase about what your thoughts are of bias in medicine. And then we have a word cloud here that'll pop up with some of the major things that have been said.
I think we see it in it manifests in areas where we might not expect it. So for example, in an era of personalized medicine where we're thinking about the use of genomics and so forth, like a lot of the data that is generated that we help to move forward care in that area is generated from biased populations. So even outside of the practice of medicine, in the development of therapies and therapeutic modalities and so forth, that's one area where you might see it.
There we go.
We have responses. Yay. We were just testing you all. Thank you for that, Steve. We've got pervasive, and that is a big word that is coming up. We've got bias, pervasive. Yeah, thank you for that.
And so I know that we have folks that are here from different divisions, not just the Division of Hematology. And so thank you all for your thoughts. Given that this is Hematology Grand Rounds, we will cover a few key issues around bias in the field of hematology. And just as a note, this is not meant to be an exhaustive discussion, but rather just an introduction to prime your thoughts for our presentation going forward. And so sickle cell disease is an inherited disorder that affects multiple races and ethnicities worldwide. However, in the US, due to the history of the slave trade, nearly all patients with sickle cell disease are Black. Sickle cell disease is considered an orphan disease by the FDA, as there are fewer than 200,000 individuals living with this condition in the US. Similarly, cystic fibrosis is also considered an orphan disease by the FDA, but the patient population of cystic fibrosis is predominantly white. Disparities in research funding and drug development are one example of bias in hematology. While fewer patients experience cystic fibrosis, there's at least 7 to 11 times more funding for cystic fibrosis, and in 2020, there were almost 3 times as many approved FDA-approved drugs for cystic fibrosis compared to sickle cell disease. And in the world of malignant hematology, it's been consistently documented that non-white race and ethnicity is associated with worse outcomes in patients. We also know that non-white individuals are enrolled in clinical trials at a lower rate than white individuals.
And like Maria shared during the introduction, I've been with the hematology division for a while. And in 2020, I was a part of the administrative team. And during this time, there was a bunch of social unrest and a lot of discussion about social justice on the top of everyone's minds. And as a part of that, the hematology division, our leadership was very, felt very emotional about that and wanted us to, form a team to see what we can do about looking at disparities within our division. So we formed the Hematology Equity and Anti-Racism Task Force called HEAT, and that contained a bunch of clinicians and staff within the Division of Hematology. And our ultimate goal was to improve the patient experience. And now as individuals, like we shared, there is bias in medicine. We all in this HEAT group believe that. But as scientists, we didn't really have the data. We didn't have the information to share like we are with you now. So our goal as the HEAT team was to build a research study to better understand the experiences of patients from underrepresented minorities within the hematology division at UCHealth. We sought to gather survey and focus group data to explore the role of implicit bias and healthcare disparities that may have occurred at our institution. And we sought to understand both the patient and provider point of view to ultimately provide higher quality and equitable care. Now, our survey design was adapted from the Kaiser Family Foundation of their survey on race, ethnicity, and medical care. And the HEAT task force adapted some questions from that study to put together a survey for our patients and providers.
And so once the survey questions were finalized, we obtained IRB approval for this project. We conducted anonymous multiple choice surveys on the perception of bias in healthcare, both in the US at large and specifically within UCHealth. We conducted surveys of both providers within the Division of Hematology and also patients. And patients could indicate if they were interested in participating in an optional interview with us. Participation was entirely optional, but there was an honor area offered, so $50 gift card if patients did participate in the interview. And so to participate in the survey, providers had to work within the Division of Hematology. They could have any role within the division, and then established patients of our division were allowed to participate in the patient surveys. Patients had to be at least 18 years of age. They had to speak English or Spanish. And additionally, they had to have access to some sort of smartphone or electronic device in order to take the survey, because we did not distribute paper surveys to our participants. And then survey flyers and patients were recruited through our inpatient BMT unit. At the check-in, check-out desk, we would hand out flyers. And then also some providers would include information for their patients in their after-visit summary materials to sign up.
And like Cassandra said, the materials for this study were mostly based on having a link and access to a web page. And that particular web page was REDCap. That was the program that we used to administer the survey and to store the data. And as you can see here, our study was produced both in English and Spanish to start with. And to focus a little bit more on the multiple choice part of the survey study, we wanted to give you access to the questions. For those of us in the audience, there are copies of the survey and the data in the back. But otherwise, if you don't mind either typing in this link or going to the QR code, you can see the specific surveys and then the data we received that we will be talking about. And this little figure on the right is the survey schema, where we asked both patients and providers 8 common questions of their general beliefs on race relating to US healthcare. And then for the other half of the survey, multiple choice section, we had questions that were directed towards providers and towards patients of their experiences as they pertain to their care at UCHealth. Now, moving to the results, we had a total of 79 participants from our provider arm of the study. Our participants were predominantly female and predominantly white. This table on the right, you can see the layout of the demographics of the providers that we had surveyed. And moving into the data, one of the main things that we would like to point out, these two questions ask, how often do you think a person's race or ethnic background affects whether they can get routine medical care when they need it, or whether they can get health insurance to pay for medical care? And this figure on the right, you can see the dark lines are the median, so that's where most people answered. And then we have the interquartile ranges. So for questions 4 and 5, providers mostly believe that patient race and ethnic background does impact access to care. So you can see it's right between somewhat often and very often. Next up, there's this other sets of questions that pertain to whether medical racism occurs when a patient and provider of the same ethnic background, or whether a patient and provider of different ethnic backgrounds. And what this does is we sought to see providers' beliefs of whether a patient's ethnic background actually impacts whether medical racism occurs. And these data here were significant. I don't have the significance value, which is surprising, but it was very significant that providers believe patient and provider race and ethnic background do have an impact on the likelihood of medical racism occurring. Now, those are part of the first part of the study. Now, these questions pertain to the provider's experiences at UCHealth specifically. Now, these sets of questions ask whether they consider our institution a supportive work environment for clinicians of color, or whether our institution is a supportive environment for patients of color seeking medical care. And this last question asks whether my institution should recruit more clinicians of color. And based on these questions, providers consider UCHealth a generally supportive environment for clinicians and patients of color. And providers also agree that UCHealth and CU should hire more diverse faculty. And you can see that in the figure on the right, the median is at agree, and most of the providers were either strongly agree or agree. Now, one thing that stuck out was question 18 and 19. These questions try to target at, I believe there are salary or compensation disparities at my institution, or whether there are disparities in promotion and advancement at our institution based on a faculty member's race. And one thing that stuck out with this is most of the providers that responded to these questions were uncertain. So this shows us that there's an overall uncertainty about the practices of compensation and promotion at UCHealth and CU. So this is something that we can look at later. On this last part of the provider study, this asked providers if they have been expected to disproportionately speak on behalf of patients or staff who share their race or ethnic origin. And then we also asked providers whether they have noticed implicit or explicit biases in colleagues related to race or ethnicity. And something that stuck out with these two questions is that non-white providers were more likely to agree with these statements, that they have been disproportionately expected to speak on behalf of patients or staff who share their race or ethnicity. And these non-white providers have noticed bias amongst colleagues more often than white providers have. And there's a unpaired t-test here that shows they're both significant comparisons. So based on all of those data, the general themes of our provider survey as they pertain to general US healthcare, our providers believe that race and ethnic background does impact access to healthcare. Our providers believe that when patient and provider race are of a different background, racism is more likely to occur. And as it pertains to UCHealth specifically, our providers do consider UCHealth a supportive environment for clinicians and patients of color. Our providers agree that our institution should recruit more clinicians of color. And many of our providers are unsure if there are disparities in compensation and promotion or advancement amongst faculty of color. And some providers have shared that they were expected to speak on behalf of patients or staff who share their same race or ethnicity. And lastly, providers have also witnessed implicit and explicit biases at UCHealth.
Okay, so now to jump into our patient data, we did have a fewer number of patients participate in the survey compared to providers. We had about 20 patients who participated, and here you can see the breakdown of various demographic factors that we collected on these patients. And so our patient population was predominantly non-white, with the highest representation being from Black patients at 53%. And our patient population was predominantly male and predominantly English speaking. We wanted to compare our patient population in our study to the Division of Hematology at large. And while we weren't able to get data on Division of Hematology specific numbers when it comes to patient demographics, we were able to get information from the CU Cancer Center at large. And so the CU Cancer Center obviously will include malignant hematology patients, but also solid tumor patients. And so one gap in this is that our classical hematology patients are not going to be represented in this patient population. And the data here is shown from fiscal years 2019 through 2022. And here you can see that our study population was much more diverse than the average population of the cancer center. And so we had more non-white patients in our study compared to who we take care of, at least from an oncology perspective here at CU. And so if we look again at questions 4 and 5, so Hunter went through it for the providers. Now let's look at it from the patient perspective. And so this is around whether or not a person's race or ethnicity affects their ability to get medical care or health insurance. And you can see here that on average, patients believe that somewhat often a person's race or ethnicity affects their ability to access medical care or to get insurance. And so then if we jump to questions 6 and 7, which have to do with whether or not racism occurs based on the race or ethnicity of the patient and provider, you can see here that patients believed that when patients and providers are of different backgrounds, racism can happen somewhat often, whereas when patients and providers are of the same background, they believe that it happened less often. And this is a statistically significant difference with a p-value of 0.003. And then if we go to question 8, so this is a new question that we'll discuss. How often do you think the average person of color avoids healthcare due to fear of racism from their providers? When comparing patient responses to provider responses, patients thought that this occurred less often overall with a p-value of 0.026. And so questions 9, 10, and 12 centered on whether or not patients at UCHealth trust their medical team or have experienced racism. And so you can see here that patients feel understood. They feel like they can trust their healthcare team. And patients here have not personally experienced racism when receiving care from, us in the Division of Hematology, but also with CU at large. So lots of our patients are admitted to general medicine teams. And so this would reflect their experience, not just with our division, but across the hospital. And so question 15 was also patient specific. Do you feel there are adequate resources to help you obtain healthcare and or health insurance? And our main finding here was that patients of color, particularly our Black patients, felt there were not enough resources to help them obtain healthcare or health insurance. And so just to review our patient themes, so their thoughts on general healthcare in the US. Patients believe that race and ethnic background can impact access to healthcare. Patients believe that when the patient and provider race are different, racism is more likely to occur. And patients think that people of color avoid healthcare due to fear of racism less often when compared to providers here. And now for some patient-specific themes from our hospital. Folks demonstrated that they have a lot of trust in their team here at UCHealth, which I think is validating for us as providers. There had been no response regarding personal experiences of racism here from the UCHealth team. And Black patients believe that more resources are needed to access healthcare and health insurance. And so this was only half of our study with the patients. Like I said earlier, people could know if they wanted to participate in an interview. And so we had about half of the participants who completed the survey say that they wanted to be interviewed. And so, we interviewed most of them. We weren't able to get to everybody due to just scheduling and timing, but we thought that going through our interview themes using the patient's own words would be the most powerful way to summarize some of our findings from interviews. And so we'll read through a couple of these quotations just to highlight the common themes that we found. And so this is from a sickle cell disease patient. They had responded, I called a friend to take me to the ER, and when I got there, they did x-rays and they couldn't find anything wrong. But I was in a lot of pain and I couldn't even stand on my own feet. For me to make my pain obvious to my caregiver, sometimes I have to move the part that is in pain so that my whole body will change, or my face will change, or I will scream in pain so that they realize the pain that I am in. Maybe they don't understand the disease process unless they see it every day. Two other folks with sickle cell gave us additional quotations. So one had said, when you have a terminal disease as a minority, you're going through a lot. First of all, you are scared for your life because I have this disease that is not curable yet. And then you have to add that extra layer that you have a disease that people don't understand. And another comment, it's a big difference at Children's. They listen, they take their time. If you feel like you need to be admitted, they work with you. At UCH, they're more eager to release you.
And for another part of our study, looking at patients that are not sickle cell patients, there was a Latina patient hospitalized for cancer care, and her parents were Spanish speaking only, while she spoke both English and Spanish. And the care team was only speaking to her in English. So she said we were not getting very accurate information because they, the inpatient providers, were not translating for my parents. Also, there were some positives, of course. A lot of our patients really shared that they enjoyed their care at UCHealth. One of the Latinx cancer patients said, aside from differences in languages, the process is very good and the attention is very good. Also, a Black cancer patient says, since I have been a patient at UCHealth, I have nothing but praise for you guys. I have never had a problem with any interactions. Everybody has been very professional and friendly too. I don't know that they had to, they just were. I'm very pleased with it. I've been at UCHealth for 30 years. So some of the common themes on our patient experiences were there are misconceptions about sickle cell disease. Patients shared about language barriers they've experienced. Patients have shared that they have a lack of supportive services. And patients also shared that they have experienced a generally good quality of care at UCHealth.
And so, since one of the main themes to emerge from our patient interviews was that our sickle cell patients often feel that there's a lack of understanding of sickle cell disease pathophysiology and management, particularly when it comes to pain management, we wanted a portion of this grand rounds to be somewhat educational, especially for folks that may not see sickle cell patients every day. And so we wanted to dive into this topic to leave you with some pearls going forward, and also to discuss how we might do better for these patients going forward. So to review, sickle cell disease is an inherited disorder due to a point mutation in the beta globulin gene, creating hemoglobin S. What's important to know is that just because there might be one mutation that two different patients share, there is not one phenotype that represents sickle cell disease. Each patient is an individual in terms of how this disease affects them. And the main issue with sickle cell disease results from irreversible red blood cell membrane damage. And so as the hemoglobin S is oxygenated and deoxygenated, the red blood cells sickle, and then over time, they're unable to unsickle. This then causes vaso-occlusion. And once that red blood cell membrane has been damaged, that's how you end up with hemolysis. It's fragile and weakened. And so the important thing to recognize is that there's multiple acute and chronic complications of sickle cell disease across all organ systems. And so acute complications can include things like stroke, splenic infarcts, acute chest syndrome, and acute pain crisis. And some chronic effects can include things like avascular necrosis of bones, sickle cell retinopathy, and sickle cell nephropathy as well. And so now let's review some common misconceptions about sickle cell disease. And so one common belief among healthcare providers is that sickle cell patients are at greater risk for opiate use disorder. This is a commonly held belief that's been proven in multiple surveys of patients. And in a comprehensive study done by Ruta and colleagues, they looked at mortality data in the US to see what the rate was of opiate overdose in various populations. And so looking at the total number of deaths due to opiate overdose from the years 1999 to 2013, Almost 175,000 patients who did not have sickle cell passed away from this condition, whereas only 95 patients with a history of sickle cell died from an opiate overdose. And so looking at the number of deaths due to opiates as a percentage of all deaths for different conditions, you can see here that opiate overdose for sickle cell disease patients is on par with that of patients who have heart disease. So the percentage was 0.77% for patients with sickle cell disease, 0.11% for patients with heart disease. And you can see that the rates of opiate overdose were much higher in conditions like fibromyalgia, low back pain, and migraine headache. And then if you look at the overall number of deaths averaged out across these years the study was conducted, you can see here that the average number of deaths for someone with sickle cell disease due to opiate overdose was 6.3 compared to nearly 11,000 for patients who do not have sickle cell disease. The second misconception is that pain is the only symptom that patients have of their disease. You know, we went through the slide earlier talking about all the different complications of sickle cell. And so while pain can be the primary reason why we might see them in the hospital, they have many other factors that influence their disease. And another common misconception is that sickle cell disease only affects Black individuals. While that might be true here in the US, this map looks at the rate of sickle cell incidence among newborns in the year 2015. You can see here that while it's predominantly in African countries, there are many other places where sickle cell disease is still present. And so let's talk about how we manage sickle cell disease patients here at the university. And so there's one medical provider who manages sickle cell patients, Dr. George, who took over for Dr. Hassel. And we're trying to build up some APP support for this patient population, but he's still the primary person who sees these patients. And outpatient support is fairly limited. It consists of, nursing support to triage messages that come through the portal, and then BIC or apheresis support if somebody needs simpler exchange transfusions as needed. And at some institutions, they have the ability to manage acute pain events in like an infusion center or a BIC. We don't have that capability here. And so most patients who have an acute pain event end up going to the ED where they're treated there or will end up getting admitted. And so when these patients are admitted, they're admitted to the medicine team, either a hospitalist team or a teaching team. And in the past, hematology was routinely consulted on all of these patients. But due to increasing consult volume numbers, this is now no longer a hard and fast rule for us as hematology fellows. It's really to the discretion of the attending that you're rounding with if you end up consulting on these patients or not. And it also is due to just awareness within the Division of Hospital Medicine for them to know to call us and let us know that their patient is here, as there isn't a flag.
Actually, we do provide very expensive pain support in the depending on availability, of course.
Mm-hmm.
So if they do have a pain device, they do have fluid and pain management that is built for everybody. So if we can get it, we can't get them here, we do get them in charity. Therefore, as well, then they go here. But we do try and get them here first.
Okay. And so just for those who maybe couldn't hear on Zoom, Dr. George is letting us know that there is some outpatient BIC support here at the university and then also the Cherry Creek office. And if we can't provide pain care in the outpatient setting, then they end up going to the ED. And so on the inpatient side here, at least, there is an FYI tab that's located in each patient chart. And there is some information on patients who are admitted. I will say that whenever I've looked at it, it appears to be a little bit out of date and not updated as often as we hope. But that's one place where there might be information on pain management plans.
That's also true because it's there in my notes in very clear detail saying what needs to be done in a little pain tab in my assessment and plan.
Yeah, I think if their pain is managed here, but there are lots of patients also who get their pain managed elsewhere. And so we may not have data on that. All right, so let's talk about a specific patient experience here at the university. And so this was a patient whose care I was part of when I was a consult fellow on the hematology service. And so we had a 24-year-old Black female with a history of sickle cell disease who was admitted for an acute pain event back in June of this year. And so she had a long history of being admitted multiple times due to the nature of her disease. And because of her prior admissions and multiple hospitalizations, she had pretty poor vascular access. And so on arrival, she was advocating for herself to have her pain managed. And so asking for specific medications or doses that she knew would work for her based on her prior experience. And she's also advocating for central access to then be able to have more rapid administration of her pain medications, since IV access had been such a problem in the past for her. And so on arrival, she lost her IV access very shortly after getting here. And throughout the stay, especially in the first couple of days that she was here, there were multiple notes, especially from nursing colleagues, noting they were concerned that she was asking for certain medications by name, concerned about her use of pain medications in this way. And so on the third day of her hospitalization, the hematology consult service was called, and the main issue that the medicine team was facing was around appropriate IV access to be able to treat her acute pain crisis. And so it turns out that someone, I'm still not sure who or why this was, put into play, but they'd put in a consult to interventional radiology and to the medicine procedure team. And in the text of the consult order itself, there was a comment saying there was concern about this patient having a history of intravenous drug use. And so naturally, with this in the consult order, the medicine procedure team and the interventional radiology team were not really rushing to put a line into someone who had this documented in their order. And so despite the fact that she was in a pain crisis, there was a big delay in getting appropriate IV access for her to start IV pain medication. And so when they called me, I went and talked to the patient, and I was just very open with her, saying that this was a concern on the behalf of her admitting team. And I asked her about it. She denied any history of intravenous drug use, and this was corroborated by her urine toxicology results that we had here. So there's never any concern for aberrant opiate use for this particular patient. And so my concern is that when she was here and advocating for herself, that somebody inappropriately concluded that perhaps she had an issue with opiate use disorder. And we were only called when this became an issue in terms of, her disposition and how to get her out of the hospital faster. And so I wanted to bring specific attention to how this patient had information documented about her in the chart. And so this is from the attending attestation for this particular patient. And so you can see here, the main problem is acute on chronic pain and setting of her sickle cell disease. And so they comment on many hospitalizations for acute pain, frequently prolonged. She's lost IV access, unable to replace, procedure team consulted, IR consulted. I'm uncomfortable with central access at the time of discharge based on underlying mental health and psychosocial issues. If hematology is willing to manage, we could consider it. And it goes on to talk about their interactions with the patient. And they say, notably, no IV pain medication this morning and appears comfortable. And they go on to talk about her plan. And then just to sort of point out, this was, in the text of the interventional radiology consult note. So given the patient's underlying mental health issues and psychosocial stressors, parentheses, history of intravenous drug use, need to determine best type of line for this patient. And so this is something that was, typed and printed into the patient's chart, and we know would follow her going forward. And so one thing that I just wanted to raise was that this note and patient experience highlight two issues that I think that we should review. The first is appropriate management of an acute pain crisis. So the team was delayed in giving her access to IV pain medications due to a future concern about line management. And the second is around how we document our interactions for patients with sickle cell disease. So in terms of sickle cell disease pain management, the American Society of Hematology in 2020 put out a guideline saying that these patients should receive rapid pain relief. The pain relief should be reassessed frequently to make sure that we're meeting that patient's needs. The second thing is that I often get asked on the consult service, what's the best way for me to figure out if this patient is actually in pain? Should I look at their hemolysis lab? Should I look at their hemoglobin? And I give the same answer every time. The best assessment of pain comes from the patient themselves. They've lived with this disease for often decades, and they're the ones that know, what their body needs. And I think this also harkens back to that patient quote that we had earlier, where they said, I'm in pain all the time, but for me to show it, I have to writhe around, I have to express that I'm in pain. It's obviously very different for somebody who lives with chronic pain compared to someone who has an acute fracture of a long bone or things like that. And so there was a phase 3 randomized control trial that looked at how we administer pain medications to patients. And so in this particular trial, they had two different arms. For one arm, patients got a weight-based treatment protocol. So, whatever percent of their weight would be administered in terms of their first time pain bolus. pain medication bolus. And for the second arm, what happened was that they actually did it as a percentage of whatever the patient's home opiate dose was. And so obviously that means that you have to know what the patient's home opiate dose is to then be able to make this calculation. If there was an unknown home dose, they would use a weight-based dosing. And this particular trial demonstrated that when we used a patient-specific treatment plan, patients often had more rapid relief in terms of their pain. And so that's something just of note going forward. So we'll come back to this. And so the second thing that I wanted to highlight is around stigmatizing language. And so in 2018, there was a study done by Godot and colleagues that looked at the effect of stigmatizing language in charts on medical student and resident attitudes towards sickle cell patients and pain management of sickle cell patients. And so for this particular study, medical students and residents, and it was both emergency medicine and internal medicine residents, were exposed to either neutral language, which you can see an example of there, or stigmatizing language about a sickle cell disease patient. And so what they found was that people who were exposed to the stigmatizing language often had more negative attitudes towards sickle cell disease patients. So here a lower score means a more negative attitude. And also for the residents specifically, they didn't ask the medical students about this. They would then ask, based on the description, what would be your pain management plan for this particular patient? And they found that there was less aggressive management of the patient's pain. Again, a lower score indicates fewer pain interventions when they were exposed to stigmatizing language compared to neutral language about the patient. And so I think it's important, with this sort of data to prove it, that it's important for us to speak up when false or stigmatizing documentation is in the chart, because it can have a direct impact on patient care. And so not only should we speak up when it comes to questions around opiate use disorder, but we should speak up whenever there's something in the chart that's not right for these patients. And so just as another example, I distinctly remember another consult I had gotten earlier this year where a hospitalist had gone through and counted every single admission that a patient had had in our system and in Care Everywhere, and had counted the number of days for every admission and gone through and sort of tallied the different pain management approaches from different hospitalizations. And it felt not in a way to provide the patient with better care, but rather to say, look at how often this person's been admitted. And so my question to the audience is, if you're, not in the Division of Hematology, since we don't manage these conditions, but if you're a hospitalist in charting for your heart failure patients, are you counting every admission that this patient has had? Are you adding up the number of diuretic doses needed? Are you including all of that in your documentation? Or for your immunosuppressed patients that you take care of, are you counting the number of infections they have every year and tallying up the cost of their antibiotic therapy? I assume the answer is no to those questions. And so I challenge our colleagues to think about what qualifiers we're putting into patients' charts, because we know that this will follow them and will have a direct impact on their care. And so for this 24-year-old that I mentioned earlier, I took the time to talk to the patient, talk to the primary team, talk to the interventional radiology team, and had them correct their documentation and actually remove it from their note because it was stigmatizing. And we know that for any 24-year-old Black female in our healthcare system, if there's a label in there of intravenous drug use, we know that that will get carried forward. And that will impact how people think about this person when they come in for care. And so thankfully, the teams did correct their documentation and removed it from her record, which I think will be important for her going forward. And so in terms of some recommendations, we can run through a couple things that we had brainstormed. So one is creation of sickle cell patient treatment plans. And so I think that for our inpatient colleagues who manage these patients once they're admitted, oftentimes we have treatment plans for things like iron replacement, IVIG administration. If we could build into Epic actual treatment plans for these patients based on the data that we have and how their pain has been managed typically, I think that would really help sort of decrease the stigma around the doses of opiates or things that are needed for them once they're admitted. The second is that Puri and colleagues had done a study to see whether or not short educational interventions could be done to improve, patients' perception of sickle cell disease patients. And so they had done a study looking at emergency medicine providers, but people who had watched short educational videos actually had improved perception of sickle cell patients and their needs. And so I think that's something that we could also employ for our Division of Hospital Medicine colleagues, or for our colleagues in the emergency department who might be taking care of our patients when we're not yet involved. I think that we could have a comprehensive care team. And so, we often have psychology available for our bone marrow transplant patients. What if we had a psychologist who was available just for our sickle cell patients? What if we had a dedicated sickle cell social worker? And what if we brought in our palliative care or acute pain services to help manage pain? Dr. George has a lot to manage with the disease itself, and managing pain can be a whole separate issue. And so it'd be something to consider for us going forward. I think that we should remove stigmatizing documentation that's in the chart, or at least challenge it. If you're not the person who wrote the note, you may not be able to edit it, but you can always talk to your colleagues and educate them. And then in general, a willingness to speak up and advocate for these patients. So, why are we letting this 24-year-old have a delay in care because someone's worried about who will manage a line, instead of just taking care of the patient who's in front of us and dealing with that issue when it comes time to deal with it.
And one of the other major themes, as we shared, that came from our study and from the interview portion of it is a disparity in language services at UCHealth. There's some patients that have experienced some poor care as a result. So as an overview, the current use of translators at UCHealth relies on the setup and the use of video interpreter iPads when needed. This could potentially be perceived as an additional task by the care team. And this is just anecdotal. One thing I have seen personally is that non-English speaking patients may be pushed towards the end of rounds, seeing some disparity in their care there. And what this kind of brings up for us is, in such a complex field such as hematology and BMT, is should we have in-person translators for rounds? There's one review article from this year that shows that in-person professional interpreters result in the highest satisfaction and communication with patients. So we think that this is something that could be addressed or further explored through more data collection and through interviewing more patients to see what their experience is like of language interpreters and then what they would prefer. Our patients also shared that hiring more Spanish-speaking providers is something they find necessary at UCHealth. Not sure of everyone else's experiences, but what I have seen myself is that most of us are only English speaking, and we do have a lot of solely Spanish speaking patients. Also, one thing that came up during the production of this study and our study design, currently IRB guidelines require study materials to be translated only after the use of 3 short forms per study. So that means that 3 patients have to require a different language than the study's main language, and they're given a very brief form of that study's materials. So it, of course, does omit some information. For us, we decided that this study, of course, should be translated upfront. So one of the major questions that came from this is, should research materials be translated upfront? Now, in the Division of Hematology at the HCTU, they're moving towards having Spanish and English study materials up front at the study startup. But this information is something that could be considered for other groups, and where just English is the main language that studies are produced in, while much of our patients are also Spanish speaking. And based on this, we thought that language accessibility should be explored in some other realms of patient materials, like the pamphlets on the board or some of the digital materials we have online. And while the Division of Hematology, we have a wonderful website, and we have a great hub for patients to see our open clinical trials, but it is only in English. That's nothing against our group, but it's just the way some things are, and some patients might actually benefit from this being in their language.
And so some study caveats. I like to think about this as a small pilot study. To our knowledge, nothing like this had been done before in the division. And so we obviously have a small patient sample size, and we didn't collect a lot of information on other demographic factors like age or the patient's diagnosis. We also didn't require patients to answer questions about race and ethnicity separately. And so we just weren't sure how people would respond to a survey like this. And so that's why we kept things very broad for this initial go around. Also, illiterate patients, patients who spoke languages other than English or Spanish were excluded just due to our limitations in terms of translating our study materials or having interviews that we could do in other languages aside from English or Spanish. I think it's also important to acknowledge that patient participation could be influenced by the $50 gift card that we were giving out for a survey for interview participation. And I think it's also important to call it the power dynamic. So patients rely on us for care. And if we're passing out survey information when someone's admitted to the hospital for their transplant, will they feel pressured that they have to do this? Otherwise, they may not get optimal care. And so I think it's just something that is important to recognize. In terms of future directions, so we've obviously seen that patients and providers are willing to take the survey and participate in this study. And so I think that we've paused our data collection right now to prepare for this presentation and also for the ASH annual meeting. But I think that it'd be very feasible for us to reopen our survey and to reopen our interviews for patients in the Division of Hematology to get more information. I think that there's a possibility for us to create actionable changes. Like I talked about those built-in EPIC treatment plans or live translators for rounds. We can expand our IRB to include other demographic factors. And so things like sexual orientation, immigration status, presence or absence of a disability. And then we also think that in the future, this is something that could be expanded to other divisions or even other institutions for them to get sort of a take on how patients are feeling about their care in their divisions. Obviously, the Division of Hematology is only one part of this huge system here. And so we could impact patients in many other ways.
And with that, I would like to acknowledge the vast group of individuals who have been involved with this study. Of course, the patients, we would not be able to do it without patients. The Division of Hematology staff, we've had probably dozens of people involved with the work on this study, and as well as people giving the response to the study. Maria Amaya, Dr. Amaya in front of me, is a wonderful human who was the study PI and a major contributor to this work. Throughout all of the heat formation, the Division of Hematology administration has been a major support, especially Dr. Jordan. Some of the materials from this were funded by Dr. Jordan's funding. And we have a whole list of a bunch of other wonderful individuals who helped us with this work.
So with that, we have one last poll everywhere for you all to participate in. And so we were hoping, we obviously offered some interventions on our end, but if people had thoughts about other interventions that would be helpful or just have comments in general about this topic, we're happy to collect them here. Also, if you don't want to participate in the poll everywhere, then you could always email us. Our email addresses are listed up there as well. And so if folks on Zoom or if folks here in the room want to take a minute to fill this out, we can probably have you all fill it out as we take any questions from either in the room or on Zoom. And we can put up responses as they start to come in.
As per patients in oncology, in particular, going on clinical trials, what are you guys doing about the Duffy null patients, which is super common? And I've run into this with people have asked me in the OB-GYN, they're saying, please see this patient so we can put her on a trial. And I said, well, if you are going to use the cutoffs for neutrophils for white Europeans, then forget about ever having anybody else in the world on your trial. And it's something that ASH is very interested in. There was this big, what did they send us? Some doctor information thing. So that's something that needs to be addressed. And as per Mary Berg, you can put in a blood bank hold specimen and say, ask for Duffy phenotype as per Dr. Berg, and see if in fact that's what they have. And, those patients aren't at risk of being harmed by your chemo or antibiotics or whatever.
Yeah, Dr. Stabler, that's a great point. I think a lot of it has to do with inclusive trial design. And so, especially for people who are thinking about writing trials, I think it's important to consider things like, do you really need that lab value to be a certain thing? whether it's ANC or even GFR. And so we know that, African American patients, depending on which calculation you use or, which reported value you use, may be excluded from clinical trial design or participation rather. And so I think a lot of it goes back to how we set up our inclusion and exclusion criteria for patients.
Really nice presentation, guys. And I've seen now 2 versions, and it's really nice to see how you've added and changed. Cassandra, I'm interested, like, if you would want to share how the conversation went, or it sounds like you've had conversations with other providers where you ask them to amend their notes. That sometimes, I've found that to be challenging. And then do you recommend, you sort of put in a note to override someone else's note, which I think in this case, was necessary to sort of correct the record, but that can sometimes be seen as like a chart war situation that we all try to avoid. So I'd love your thoughts on those 2 things.
Yeah. I think people who know me know that I'm not afraid to speak up when I think something is wrong, which is perhaps a good or bad thing. And so the way that I think the consult system works is that the person who had triaged this interventional radiology consult wasn't actually, I think, on service the day that I saw the patient. And so I'd sent them a message, a staff message on Epic and a secure chat asking them if we could talk about it. And so for that day, I had put in my note, like, this is stigmatizing language, it should be corrected. I think that, I talked with the teams, the medicine team primarily, who had her that day. It wasn't until the next day that I could get a hold of the interventional radiologist who'd put that in the note. But I think that it's a learning opportunity, especially for our trainees. This patient was on a teaching team. And so I, talked to the resident, I talked to the attending, who is someone that I know, and we just had a discussion about it. And they were sort of like, oh, we don't even know how this got into the chart. And I'm like, well, it's there in the consult order. You can go back and see that someone thought to put this in the note. And so I think that if you approach it from a place of wanting to help the patient, that most people are often receptive in terms of hearing this. I think if you approach it being like, you don't know anything about sickle cell disease, why are you doing this? Then it's obviously taken very differently. But I feel like when I'm on the consult service, I try and have open and honest conversations with the people who are consulting, from us. And so I think that that's something, and it's, I think, varied in terms of its success. I think I've had more success with younger attendings or hospitalists. I think people who are more established, it's been a little bit harder for me to break through and to get them to change their documentation. But it's not for lack of trying, at least on my part.
Yeah, I would like to commend Cassandra for that. That was tremendous work. I think most people would have just brushed it off and not just ignored it. I think you went above and beyond. Thank you very much for that. That made a huge difference to that patient's psyche.
Yeah, and honestly, like, I told the patient, I was like, somebody put this in your chart. I know, like, I don't think it's true. And she was like, that's absolutely not true. That's so racist of someone to put this in the chart. And I looked back at her chart now, and since she's gotten her report, her average length of admission is 3 days, and she's been only admitted twice. And so she had this like terrible, like 9 or 10 day admission where all of this was going on. And just by giving her like appropriate access with somebody who would manage her line in the outpatient setting, I can only imagine, so I haven't had the chance to talk to her again, that her quality of life has improved dramatically, at least in terms of from the time being in the hospital.
So I want to thank both of you for your work on this and your leadership on it. It's been really wonderful to see this evolve. I'm quoting Dr. Chopra now, who just a couple of days ago, I happened to attend an event he was at. And the quote, which he was borrowing from somebody else, is, if you don't put money into DEI, you don't really believe in DEI. And so what I'm going to challenge both of you with is to think about, with some money behind it, of all the things that you listed, whether it's translational services, additional training on bias reduction, and so on and so forth, what is your prioritization in terms of what we could do? And given varying amounts of money, for 20,000 we could do this, for 40,000 we could do that, and so forth. And I think we should take a proposal to DOM where maybe the division would kick in, they would kick in, and let's put some money behind this, right? This is something that we can all chip in for, and I think that would be a really great thing to do. My question, that was my comment. My question is, I would imagine that the patient experience is very much shaped by a huge compendium of people that people encounter at the hospital. So in your experience in conducting these surveys, how similar or dissimilar do you think the patient experience is with respect to any of the biases or the disparities they encounter with different parts of the hospital, whether it be the MA that greets them versus the nursing staff versus the providers and so forth? Do you see significant differences there, or are hospital partners doing a good job too?
So I think, were there any particular things that patients said of whether it was provider or front desk staff or otherwise in the interviews? I think that was the question.
So I interviewed some of the patients, and Maria also interviewed some, so we can talk about that. I will say that based on the patients that I interviewed, most people were very pleased with their care here. The only things that came up were a couple times around when we had traveling nurses taking care of patients. Patients noticed that because they felt like their care was a little bit different when a traveler was present as opposed to a nurse that knew the system. And so that was one thing that came up on my end. The second thing is that sometimes patients felt like it was hard to get a hold of someone. And so I don't know if that has to do more with just like the portal and who controls messaging back and forth. Those are two things that came up for me. Really, like by and large, a lot of the things that patients had problems with seemed like more systemic issues. I didn't have any like particular themes between like levels of providers. But I don't know if Maria had something different in her interviews.
And that might be something that could be factored into future data collection of this.
Yeah, and I would say, so I interviewed a lot of the sickle cell patients, and there were some themes in the sense that, and I think hopefully it came across in the presentation about feeling that their disease, that providers understand their disease. So for example, they had nothing but praise for Dr. George and our sickle cell clinic. They felt really understood. They felt safe. Same with our BIC. And then once you start going further and further away from people who understand their disease, and they feel less comfortable. So, you know, the feedback we got from the emergency room or some of our, you know, inpatient teams, it just was more provider dependent. And then there was one extreme of a sickle cell patient who spends part of her time outside of Colorado. And she said she was deathly afraid of going to the hospital in another state where they didn't know her disease and they didn't know her treatment plans. And so I think that's where, you know, education to our colleagues and just, you know, ensuring that we all kind of understand the disease and they have a really good treatment plan, even if it's outside of here, they help with that. So I think that was maybe one of the themes. But aside from that, no particular, they really seem to be happy with a lot of the care they get at UCHealth, in particular from our team.
On that last slide, on I think it was one of your last slides there, you know, talking about data collection and having a lot of this data is really powerful, I think. And one of the comments about sort of collecting some of this data from the IRB standpoint, you know, we always fill out these things that sort of put the demographics for all the patients that go on trials. And I think collecting more of or better demographic data would be really could be really informative and really helpful. You know, collecting like socioeconomic status, like sexual orientation, gender identity, all these things could be really great and great data and really help us. I don't know that we that we routinely collect the data. I think is one challenge, but it might be something worth, you know, discussing with the COMERB chair, because I think this could be really helpful. And I wonder if there might be other IRBs around the country that do collect different demographic data that you could also kind of look at as a potential something to consider.
The information we collected was based on the IRB's default ethnicity and demographics survey, a questionnaire that they have. So that was one big thing we thought about, was for our future in this study is to include more patient characteristics. And one thing that also stuck out was particularly disease state was not collected in this. It was just through our patient interviews that we got mostly the sickle cell specific information. So expanding the demographics is going to be helpful.
I have one more request I'd like to just to chew on at least. At the last renewal of the Cancer Center grant, I think you guys probably know this already, but the Cancer Center was deemed unacceptable with respect to access to clinical trials for underrepresented populations. And so that's a particular sweet spot that I think of all, there's so many things to think about here, but that's something I think the division, at least with HCT and what we do here, could really pay attention to and hopefully synergize and partner with the Cancer Center that I think you're sort of uniquely qualified to address. And so I'm just sort of asked to put that on your radar to maybe think about that going forward. It'd be really great. Christine, did you have?
Oh, yeah. This was really great, guys. Thank you for showing all this data. I was kind of curious why you think we only had 20 patients who took the survey. I feel like understanding the perceptions of patients who are treated in experience, understanding the experiences of our patients that we take care of is just so important. If I guess if there's any way if we keep doing the survey, if there's ways we can help you guys with recruiting more patients, I feel like it's just so important to understand what our patients are experiencing. So I don't know if there's ways to do maybe a red cap survey that goes to their My Health Connection or iPads they could fill it out in the clinic, or I feel like more data could be really helpful here.
Yeah, I had created a dot phrase for the after visit summaries and shared the information with like the benign and malignant hematology groups. I think that requires providers to go in and put the dot phrase into the ADS, and so maybe getting the nurses to do that would be more helpful. I'd also thought about just like mass messaging every week's clinical patients. I didn't end up doing that because I didn't know how the division would think about that, and I figured like let's just see what we get in terms of people who are interested. But I think that going forward, like every person that I talked to and that Maria talked to, like expressed a lot of gratitude to share their thoughts. And so I think that knowing now that we have a baseline to work from where it seems like patients are interested and willing to participate, I think sending messages, mass, MyTort messages to the division, like is something that we could do. Like other groups already do it across the hospital. I know that I get a bunch of things in my own like health portal. And so I think it's something that we could certainly do going forward.
I have a comment on that too. Certainly one of the issues affecting this was the lack of distribution. It was mostly Cassandra, Maria, and I trying to get the study materials out. But one thing we have discussed is that, as you saw, the 20 patients we collected data on were mostly non-white patients. And we thought that either the study materials or the way that the study is handed to or is presented to the patients may make some white patients think that it's not for them to fill out, even though that's certainly just as useful for us.
I was good job. I was just wondering, because I remember at the beginning of your presentation, you were making the comparison between sickle cell research and CF research. I worked in a research lab for CF, and so I was just curious, like for this study at least, because one of the big things that they like shove down your throat is like the emphasis on having like your immediate family also understanding what's going on to support children, obviously because CF is like a childhood disease. That's how they like present it, and that's how they sell it. So I was just curious if there's something like that, if you would ever take something like this and start applying it. I know your inclusion criteria was 18 plus, but I assume there's a lot of sickle cell patients that are also kids, right? And like their families are the ones that have to advocate for them, because obviously like kids they're not gonna know that this is happening to them necessarily as directly. So I was just wondering if you had any ideas or any thoughts of expanding it to that kind of population as well, just because I feel like that probably affects a lot of your patient population.
I think that would fall right in line with our hopes to create a plan of care, one for the providers, but also a plan of care for the parents of the patients and how they can advocate for their children to the providers. But likewise, I think that could be just as useful for some adult patients of how do I advocate for myself with sickle cell? If I'm not, we talked about like an after visit summary where if patients go to a different hospital system and the providers there don't know anything about their pain crisis or their sickle cell disease, having a sort of form where they show I'm worth getting healthcare. Yeah, that would be nice too.
And I think logistically, we would probably need to work at Children's because like Dr. Maya and myself don't work there. So we would need to have somebody at Children's to be willing to sort of spearhead it there. But I think that there's probably interest at Children's.
Thank you. thank you all for your time. I think we went a little over, but it was a great discussion, and we really appreciate the opportunity to be here. Thank you.
I don't know. They're 100%. No way that they're. That's what I thought last time.